Thank you, Dr. Prabudh. At the outset, I would like to thank the organizing committee, Professor Sushmita Bhatnagar, Professor Basant Kumar, for giving me this opportunity. Dr. Prabudh has made the things very clear that how exactly do we do the genetic analysis and what are the factors, what are the various roles. So I will be focusing on the clinical aspects of it. So this is a famous pediatric radiation oncologist, Professor Giulio D'Angio, and he said that the oncology should be seen through the prism of Wilms. Now let us try to discuss this particular topic through the prism of Wilms. We all know that Wilms tumor, we are able to achieve the more than 90% 5-year overall survival. And this was possible because of the multiple cooperative group studies and ultimately the risk stratification of these tumors, incorporation of age, staging, histopathology into the risk stratification and leading to the more than 95% 5-year overall survival. But still, there are certain problems. We still, the outcome is suboptimal in anaplastic Wilms tumor, bilateral Wilms tumor, and in recurrent Wilms tumor. Now, and there are problems related to the chemotherapy-related toxicity. So, to overcome all these issues, the COG recently has incorporated molecular markers also within the risk stratification, and COG includes now the loss of heterozygosity at 1p and 16q within the risk stratification to identify those favorable histology Wilms tumor where we need intensification of chemotherapy. So now we know that even in Wilms tumor, this risk stratification includes molecular markers. Now, what exactly are we trying to look when we are looking for the genetic changes or molecular alterations? These are either the mutations or the numerical or segmental chromosomal aberrations, the loss of heterozygosity, fusion translocation genes, gene amplifications. So these are the various changes we identify within the tumor cells, and based upon that, we decide whether these can be used for the diagnosis or other things. So now molecular alterations can be somatic alterations or germline alterations. Now somatic alterations are those which are present within the tumor cell. So when we do the tumor biopsy, then these somatic alterations are identified, and because they are present in tumor cells, these can be used to diagnose for the diagnosis, prognosis, and the targeted therapy. Now, while the germ cell alterations are present in all the cells of the body, so this can be utilized to identify those patients where the genetic predisposition syndromes are there. So the germline alterations, if they are present, then they will be useful for diagnosis, prognosis, and all targeted therapy, but will also be useful to diagnose the genetic predisposition syndromes and for screening purposes. Because sometimes the parents come to us, my child had cancer. Now, whether the other child is also going to have the cancer, what are the other family members, whether they are also at risk. So if the germline alterations are there, then, and it has got a high penetrance and expressivity, then there is high likelihood that other family members may also develop these cancers, and these family members should also be screened. So this is the importance of germline alterations. When we talk about the role of genetic markers, the clinical aspects may be in the diagnosis of the tumor. So there are certain specific genetic changes. If we identify those, then we may be able to identify that particular tumor type. So like SMARC B1, if it is identified, that it can help us in diagnosing congenital mesoblasthic nephroma, rhabdoid tumor of kidney, PAX-FOXO1 fusion genes, they are seen in rhabdomyosarcomas. So this can be helped in diagnosis. Similarly, prognostication. We know means neuroblastoma. Means neuroblastoma has got various courses. It can spontaneously regress. It can have a benign course. It may have an aggressive course at the time of presentation only. There may be metastasis and all. So this all thing, if we have to talk about the single most important factor that is determining the prognosis, is probably the anemic amplification. So this again also can be detected through the genetic analysis only. Then risk stratification means in various tumors, it has been incorporated in the risk stratification. I already talked about the Wilms tumor. In the neuroblastoma also, and amplification, if it is there, it becomes a high risk irrespective of age, stage, histology and all. So again, it is important for prognosticating the patient's risk stratification. Detection of early response to therapy. Now, this is a liquid biopsy. Means if I will talk about the liquid biopsy in detail after in 1 or 2 slides. Then targeted therapy means Professor Samir Bakshi has already talked about it regarding the role of immunotherapy and how can we target it. Now, targeted therapy, if we are able to, take out this aspect of the genetic changes and then use it in targeted therapy, the chemotherapy related toxicity also can be decreased. Then precision medicine. Now, precision medicine is the individualized treatment. And we cannot think of precision medicine unless we talk about the genetic changes within the tumor. So the precision medicine is almost all is dependent upon the genetic markers, the genetic testing and all. And then the parental counseling means to tell the parents that whether the other family members are also at risk or not, and whether the other child is also has a possibility of having this particular tumor, and genetic predisposition syndrome. So these all are the wide aspects which can be utilized. Now, if we talk about specifically the individual tumors, the neuroblastoma risk stratification, I already talked about. Now, anemic amplification, but there are other aspects also like DNA copy number. Now, hyperdiploid tumor in infant, if it is there, it has got a favorable prognostic marker. Similarly, the segmental chromosomal aberrations like 11q loss, that also makes it an unfavorable prognostic marker. And now targeted therapies, ALK inhibitors. Now, ALK is considered to be a prognostic marker and it is a potential target. The ALK inhibitors like crizotinib is being investigated in neuroblastoma also. Wilms tumor, we already talked about the loss of heterozygosity at 1p and 16q. Then there is an 11p methylation. There are, the group of Wilms tumor patients, we all know about the chemotherapy related toxicity. How can we reduce the toxicity? Then these multiple cooperative group trials, they try to identify those patient groups who can be treated only by surgery. Now, for that, the certain criteria was defined. One was the age should be less than 2 years. The tumor weight should be less than 550 grams. Histology should be favorable histology. And even after taking all these into consideration, it was found that some of these patients were still having recurrence. Now, what is that factor that is leading to this recurrence? So then this 11p methylation came and it is being investigated extensively and maybe incorporated within the COG trials also to identify those patients where we can treat them only by surgery without giving chemotherapy and radiotherapy. Now, targeted therapy, again, the anti-CD56 antibodies are being investigated and the CAR cell therapy. Rhabdomyosarcoma. Now, rhabdomyosarcoma, when we talk, and classify these patients and stage these patients, the age and the site and histology. These are considered to be the two most important factors. Now, favorable site, whether it is favorable site or unfavorable site, whether the histology is alveolar histology or embryonal histology. Now, then came this changes, the fusion genes PAX and FOXO1 fusion. So it was seen that the embryonal carcinoma, histology embryonal rhabdomyosarcoma, who are having, suppose, PAX FOXO1 fusion gene positive. Now, that will behave like an alveolar rhabdomyosarcoma. So, the more important aspects of histology, instead of histology, it is these genetic markers which either they are present or not. So, nowadays, we classify whether they are fusion positive or negative. And if the embryonal rhabdomyosarcoma is fusion positive, it is treated in the same lines of alveolar rhabdomyosarcoma and considered to be a poor prognostic factor. And similarly, now drugs are being studied where we can decrease the expression of PAX FOXO1 gene and for the maintenance of relapsed rhabdomyosarcoma, the mTOR inhibitors like temsirolimus is also being investigated. Now, germ cell tumors. Now, so there are certain germ cell tumors where we need to do the karyotyping because they are associated with certain the genetic conditions like the mediastinal tumor in boys, they are associated with Klinefelter syndrome. Now, gonadoblastoma, again, karyotyping is needed. It may be associated with Turner syndrome, Swyer syndrome, gonadal dysgenesis. So these are the conditions where if these tumors are present, the karyotyping should be done in these patients. Similarly, it can be used as a diagnostic marker in Sertoli acute cell tumor. Dicer1 genetic marker is there. Now, Dicer1 is also utilized for pleuropulmonary blastoma. Now, sometimes there is, a neonate antenatal diagnosis of a congenital cystic lung malformation is there. We do not know whether it is a pleuropulmonary blastoma or it is a CPEM. Now, if a Dicer1 mutation is, looked for, then we can label it as pleuropulmonary blastoma and can treat them more aggressively or doing the early surgical resection. Liquid biopsy. Now, at present, to diagnose these tumors, what we do is the tumor biopsy. A tumor biopsy has got its own issues. Now, there may be certain tumors which are present in inaccessible areas, or the tumor heterogeneity is there. We are hitting those areas which are having necrosis or they are not representative of the sample. Now, this problem is sorted out by doing a liquid biopsy. What we do is that, we know that these tumors are secreting the cells and they can be isolated by isolating the circulating tumor cells or cell-free DNA or cell-free RNA. And then we can differentiate whether it is a tumor cell or a normal cell based upon the particular markers that are present in these tumors and tumor-specific mutations. So if a tumor-specific mutation is there, we know that it is a tumor cell, it is not a normal cell. Then, it can be diagnosed. Then another aspect is you have diagnosed the tumor, started the treatment. Now you want to look for the early response. Now, doing a repeated biopsy of the tumor may not be feasible. So, tumor liquid biopsy, just take a sample from the blood or synovial fluid, CSF fluid, depending upon where exactly the tumor is situated. And then, trying to determine whether those levels which were there previously, it has come down or not. And based upon that, we can sequentially do the surveillance of these tumor. It can be used in follow-up and detection of recurrence, etc. So it has got significant role. Now, this is a study which was conducted by Dr. Saray et al. Had done this study, and they tried to identify the role of genome sequencing in pediatric solid tumors. So when they did this study in about 367 patients, and what they found was that this genomic sequencing, it led to therapeutic impact in about 50% of the patients. What do we mean by therapeutic impact? That if because of this next generation sequencing, we were able to either escalate the therapy, de-escalate the therapy, or it was used in risk stratification. And also we identify certain markers which are seen in germline alterations also. And if these are seen, then these patients were investigated or other family screening was also done to look for whether other parents, other kids or other family members were also affected by this tumor. So it got a significant impact in those patients wherever this next generation sequencing was used to, in those pediatric solid tumors. So to conclude, we can say that it has got a significant role in diagnosing, prognostication, and risk stratification, and it should become a standard of care for pediatric solid tumors. Thank you.